Incredibly, septicemia affects 50 million patients every year, and that accounts for 10 to 11 million deaths globally. For all of us, that translates as one family losing a loved one every 2 to 3 seconds.
In this episode, we examine the global burden of sepsis through the COVID-19 lens. We've got some of the top experts from around the world focusing on the practicalities of moving the needle, so to speak, in the fight against sepsis.
We're proud to collaborate with MSD on this educational project. MSD is committed to combating infectious diseases, to tackling antimicrobial resistance, and to coming up with new ways to face this current pandemic.
So wherever you are in the world, we ask that you take a moment to acknowledge the traditional custodians of the land on which you stand.
Welcome to Coda Zero.
So Elizabeth, we know that one of the first-line treatments of sepsis is timely and appropriate antibiotics, but also on the other side of things that antimicrobial resistance is a real threat, and particularly in lower middle income countries, which Flavia could contest to. So can you, Elizabeth, from your perspective, what are the key issues that COVID-19 pandemic has highlighted for antimicrobial resistance and stewardship?
Sure, thank you for the question. I think, first of all, the SARS-CoV-2 virus, the virus that causes COVID-19, has really highlighted our vulnerability to infectious diseases in general. We have now been able to experience firsthand the public health and economic costs of a pandemic, of infectious diseases. And we know now what it means to not have effective diagnostics, treatments, and vaccines when we need them. So we just saw some of the numbers about the deaths due to COVID-19, and using that same Johns Hopkins tracker, as of yesterday, there are about 690,000 deaths around the world. But we have to account for the fact that COVID-19 was a surprise. It was an ambush. We didn't know that it was coming. So that is a horrible number. And we don't like to hear about that amount of deaths due to anything. But AMR, or antimicrobial resistance, we know we have a problem with, yet we still today have about 700,000 deaths due to AMR every year. And that again highlights the impact that not having effective diagnostics, treatments, and vaccines where we need them can have. And for antimicrobial resistance, where we know it's a problem, we just simply shouldn't be in a situation where we don't have effective diagnostics, treatments, and vaccines. So with COVID-19, another thing that we've seen from the lack of diagnostics, treatments, and vaccines is increased antibiotic use. And we know that antibiotic use is a key driver of antimicrobial resistance. And so some of the use that we're seeing with COVID-19 is likely appropriate, but much of it is probably inappropriate. And this is where antimicrobial stewardship, or AMS, comes in. And so I do just want to take a moment to clarify what I mean when I talk about antimicrobial stewardship, or AMS, because oftentimes when you use that term, what people first think about is the so-called antibiotic police. And unfortunately, that is due to how antimicrobial stewardship is often practiced, which tends to be somewhat of a drug cost minimization program. But what antimicrobial stewardship, or AMS, is really about is the responsible use of antimicrobials. So selecting the right drug, dose, and duration for an accurate diagnosis in the right setting of care, and de-escalating therapy when appropriate, in order to optimize patient outcomes and minimize those unintended consequences of antibiotic use, such as AMR. So this is what I'm referring to when I talk about antimicrobial stewardship, not the antibiotic police. So COVID-19, I would say, has really highlighted the impact of infectious diseases and our vulnerability to infectious diseases. And again, the importance of having effective diagnostics, treatments, and vaccines, and the importance of using those tools responsibly.
Thanks, Elizabeth. So you mentioned that you're seeing an increase in antibiotic use. So why do you think this is, particularly that COVID-19 is a virus and antibiotics don't work against viruses?
Well, that's a great question, and a very important point to emphasize is that antibiotics work against bacteria, not viruses. So why are we seeing increased antibiotic use with COVID-19? I think there are two primary reasons for this. First, we've actually learned from sepsis the importance of early appropriate therapy. We know that when you have delays in appropriate therapy for sepsis, you see increased rates of mortality. And so clinicians are aware of this, and this concept has been extrapolated to other areas of infectious diseases as well. And clinicians want to get something on board as soon as possible because, again, we know the importance of early appropriate therapy. In addition to that, many of the features of COVID-19 are difficult to differentiate from bacterial infections. You have fever, shortness of breath, hypoxia. So you have a situation where clinicians know the importance of early therapy, and they have a clinical syndrome that might be difficult to differentiate from bacterial disease. And then on top of that, we don't have widespread availability of effective treatments for COVID-19 yet. And so in this situation, again, clinicians want to get something on board for whatever may be causing the issue as soon as possible. And in some cases, that means antibiotics. The second primary reason that I think we're seeing this increased use of antibiotics is due to our experience with influenza in the past and what we've seen as relatively high rates of bacterial co-infection or secondary bacterial infection. So rates up to about 35% in influenza patients. So clinicians, I think, with COVID-19 have a high suspicion for secondary bacterial infections or co-infection. Now, some studies with COVID-19 have shown that that rate of co-infection is actually lower, so closer to about 8% co-infection or secondary bacterial infection in COVID-19 patients. Yet 72% of COVID-19 patients are receiving antibiotics. So a caveat, though, to that lower rate of bacterial co-infection is that those bacterial co-infections or secondary infections are still a significant contributor to the mortality that we're seeing with COVID-19. So some studies have shown that about 50% or half of the patients with COVID-19 that die have a bacterial co-infection or secondary infection. So this relatively low rate of bacterial infection, in addition to the high rate of antibiotic use and the high mortality burden in those cases where co-infection is actually documented, really highlights and emphasizes the need for antimicrobial stewardship again.
Yeah, so thank you, Elizabeth. I'm just wondering, Flavia, if you'd like to make any comments on this, excuse me, particularly around that in Brazil, I'm sure the rates of antimicrobial resistance are high. So from your perspective, do you want to make any comment?
Yeah, I fully agree with everything and all the concerns that Elizabeth has raised. And we have to put it in context because, yes, in low and middle income countries, healthcare-associated infections and multi-drug resistance are quite much more common than in high-income countries. We already know that by the literature. And I believe that COVID just strengthens this weakness. What I mean, we are without supplies to do proper, to deal with these patients. We have a shortage of the stewardship personnel and also supplies for this. We are now with difficult, for instance, to measure colonization of our patients. And as Elizabeth has mentioned, although co-infection and secondary infection seems to be low based on high-income country data, I'm not sure about us. Yeah, we have a huge problem with that. Our mortality rates are much higher, and I believe that most of our patients that die, they do have a secondary infection, which raises a visceral sickle, where we have to do a very broad spectrum empiric therapy when these patients are severely ill. And then we are just maybe overusing antibiotics. And there is another issue. There is a cultural problem. I believe that regardless if you are in a high-income country, a low or middle income, nobody has 100% compliance with hand hygiene. And now that we are working protected with the gloves, for instance, it's different because one of the drivers for hand washing is the sensation that you touch the patient and now you're dirty. So you have to clean your mouth. And with the gloves, it does not happen. So it's much, much worse to train people. And there's another issue. We have a shortage of well-trained healthcare workers because we double our ICU beds. And a bed needs healthcare workers to work with. So there are quite a lot of untrained people. So it's a huge issue. It was a huge issue, and now it's much bigger.
Yeah. Thanks, Flavia. That's a really interesting perspective, particularly about the feeling protected as a health professional. So, Elizabeth, we'll just maybe touch on the roles of vaccines and their role in antimicrobial resistance, and if a COVID-19 vaccine would help.
Sure. So vaccines can really play an important role in antimicrobial resistance by preventing infections. And through preventing infections, there are two primary things that vaccines help with. They can reduce the carriage and transmission of antimicrobial resistant pathogens, and they also reduce the presence of clinical symptoms that may result in antibiotic use. So when we think about vaccines, we can think about three broad categories in the context of helping with antimicrobial resistance, or AMR. So the first category would be vaccines that prevent commonly acquired bacterial infections that subsequently would result in relatively widespread antibiotic use for those bacterial infections. The second category would be vaccines that prevent specific infections due to an antimicrobial resistant organism. So something like TB or gonorrhea. And again, that's the case where those vaccines would also help prevent the carriage and transmission of those specific antimicrobial resistant pathogens. And then the third category is vaccines against viral illnesses that ultimately may result in antibiotic use, whether it's inappropriate antibiotic use to treat the primary viral infection, which we know antibiotics don't work against viruses, or appropriate antibiotic use to treat a secondary bacterial infection like we were just talking about. And so your question about would a COVID-19 vaccine help address antimicrobial resistance? Yes, because a COVID-19 vaccine would fall into that third category of preventing a viral illness that ultimately may result in antibiotic use. So all three of those categories that I just talked about would help reduce overall antibiotic use. And as I already mentioned, we know that antibiotic use is a key driver of antibiotic resistance. But what's important to mention, so for COVID-19, I believe now there are over 160 vaccines that are in development, with about 25 of those in human studies. So I think we can feel relatively optimistic about the likelihood of a COVID-19 vaccine. But vaccines only work and will only help address antimicrobial resistance if people get vaccinated. And vaccine hesitancy is a key contributor to infectious disease outbreaks around the world, as we've seen with measles. We've also seen polio in the Philippines. And so public trust and confidence are really at the core of successful immunization programs. And we need to remember that not only for antimicrobial resistant relevant vaccines or specific vaccines, but for all vaccines, including future COVID-19 vaccines. And it's really concerning with COVID-19 because one example is just a poll that was recently conducted by CNN in the United States suggested that about a third of Americans would not get vaccinated against COVID-19, even if a vaccine was readily available and low cost. And so this public trust and confidence is really an issue that we need to address. And it's relevant, like I said, for all vaccines, AMR and COVID-19.
Thanks, Elizabeth. You've actually answered the audience question around the main hurdles, I think, with COVID vaccine in respects to vaccine hesitancy. But Simon is desperate to ask a question.
Yeah, I'm really worried that, there's like, as you said, there's I thought it was 120. I mean, that was probably yesterday. Now there's 160. And they're going into clinical trials very quickly. We hear even respected people like Anthony Fauci talking about having one by the end of the year. I'm really worried, I mean, we all want a vaccine, and there's the worrying data from people who've been infected that the antibiotics maybe only hang around, Get the right word out. Not the antibiotics, they hang around forever. The antibodies might only hang around for a month or 3 months. So we could have a vaccine that produces immunological response. My worry is around this kind of vaccine hesitancy, anti-vax movement, etc. If we rush these vaccines in and go and vaccinate a whole lot of people and cause a whole lot of adverse effects, we could harm the well-established vaccination programs where we know we have safe vaccines that save millions of lives. If people rush too quickly and start vaccinating people and that we see a whole load of side effects because they haven't been through the normal development process of a vaccine, it strikes me as it's just a little bit worrying.
Yes, I agree with you. And I think the message that we need to keep sending is that speed is important. And in a situation like this, we certainly recognize that speed is important, but not at the expense of safety and efficacy. And so we absolutely need to make sure that the vaccines are safe, effective, and durable. The point you brought out about the duration of immunity. That's also very important when you think about development of a vaccine.
Thank you, Elizabeth.